All right, perhaps we'll get started then. Welcome everyone. I'm Jeremy Chalk. I'm a public health registrar working with the NACCHO cancer team, and I'm very pleased to join you today to provide an overview of program entry and eligibility for the National Lung Cancer Screening Program, which, as I'm sure you're all aware, is launching soon on the 1st of July. So it's great to see a lot of people joining us today from both the ARCHO sector and outside the sector. So thank you today for joining, and let's jump in. So of course, I'd like to begin by acknowledging the traditional custodians of the lands from which we're all joining today. For me, I'm very privileged to live and work on the lands of the Wurundjeri Woi-wurrung people in Naarm. I'd like to pay my respects to elders past and present and extend those respects to any Aboriginal and Torres Strait Islander colleagues joining us today. So just a bit of housekeeping to begin with. Please keep your microphones muted during the presentation, although I think the webinar function might do that for you. There is a Q&A function for you to ask questions, so please use that. The team will do their best to sort of answer questions as the webinar proceeds, but if there's anything we can't answer or don't get to during the webinar, we'll collate these into an FAQ document that we'll circulate after the webinar. Also, just use the chat for any comments you may have. We'll also be posting some links to resources and that sort of thing in the chat as well for you to access. And to let you know, today's session is being recorded. So the recordings will be made available following the webinar. And just thank you to the Australian Government Department of Health, Disability and Ageing for funding this webinar. So a bit of an overview of what we will be covering today. So I'll start by providing a bit of introductory information, including a brief overview of the screening pathway. We'll then go into information on promotion and awareness of the program and program entry. Then cover eligibility assessment. So this will include the eligibility criteria, the smoking history assessment, and a proxy approach that NACCHO has developed to assist with assessing the PAC-year history criterion. And then we'll cover the next steps if eligibility is confirmed. So the shared decision-making process, doing a low-dose CT scan suitability check and the request form, and the NCSR enrollment as well. We're then very lucky to be joined by Dr. Alice McGushan at Woononga, who's going to showcase some of the preparation Woononga's been doing in the lead up to program launch, in particular using their clinical software, Communicare, to ensure they have good workflows in place to support their staff and participants. And then we'll wrap up with a bit of extra information on resources and education that's out there to help you get ready for the program launch. So the National Lung Cancer Screening Program will be the first new national cancer screening program in almost 20 years. The program will target high-risk individuals to detect lung cancer in its early stages to increase the likelihood of successful treatment and to improve lung cancer outcomes. So large international randomized trials have shown that screening with a low-dose CT scan can reduce lung cancer deaths by at least 20% and detect up to 70% of lung cancers at an early stage. So you can see in the picture to the right there at the bottom, without screening, typically less than 1 out of 10 lung cancers are diagnosed at an early stage. But with lung cancer screening, we can get that up to 7 out of 10 lung cancers diagnosed at an early stage when it's easier to treat and we can get better outcomes. So the screening program will be particularly important for Aboriginal and Torres Strait Islander peoples who are diagnosed with lung cancer at twice the rate of non-Indigenous people in Australia and experience a higher lung cancer mortality rates compared to non-Indigenous Australians. So you're probably aware by now, the screening test is low-dose CT scans of the chest. They'll be available through fixed site radiology providers and Heart of Australia have also been contracted to provide mobile screening in some rural and remote communities throughout Australia. And eligible community members can be screened every 2 years or more frequently if needed, depending on the findings of their screening scans. So here we've provided a simplified version of the screening pathway to illustrate the key elements that map the participant journey. So beginning with promotion and awareness in the top left, it's sort of important for all health staff to do their best to try and raise awareness with community members and promote the program so people know what it is and know what it's about. It then provides the eligibility criteria for the program, which we'll go into in more detail in subsequent slides, and then program entry, so identification of potentially eligible participants and inviting them to discuss lung screening and for an eligibility assessment. So below that, it then moves on to enrolment and shared decision making. So once eligibility has been confirmed, the client needs to be checked if they are suitable to have a low-dose CT scan, and I'll give a bit more information on that in a later slide. And then enter into a process of shared decision making to ensure they're making an informed choice of whether to participate or not. And if they'd like to participate, you'll then need to provide them with a request form for the low-dose CT scan, and they can book themselves in at a participating radiology service to go and have the scan. So moving up to the screening box in the top middle of the pathway there. Once they've had the scan, this will be reviewed by a radiologist who will document the findings in a structured radiology report that is sent to the practitioner who requested the scan and also uploaded to the NCSR, the National Cancer Screening Register. So you can see in the top right there the various risk ratings the radiologist will use to categorize the findings in terms of whether they detect any nodules and what those nodules look like. So very low risk is the lowest risk. And for these individuals, they just need to return for their 2-yearly scan in 2 years' time. Then for low risk, moving through to moderate risk, in these instances, a nodule or nodules were detected that just need to be monitored to check for any changes over time. So for low risk, these individuals need a follow-up CT in 1 year. For low to moderate risk, they'll need a follow-up CT in 6 months, and for moderate risk, a follow-up CT in 3 months to keep an eye on that nodule and see if there are any suspicious changes or it grows. So those are called interval scans. And then for high risk or very high risk, these are nodules that look suspicious for lung cancer. So for these, they are referred to a respiratory, you'll need to refer to a respiratory physician, ideally linked to a cancer multidisciplinary team for them to undergo diagnostic assessment. And then, of course, it's a scan of the chest, so it may pick up non-lung cancer related findings in the lungs or elsewhere in the chest. So actionable additional findings will also be reported in the scan report, along with recommendations of what to do next and how to manage these. So in terms of how results will be communicated to the participant, the National Cancer Screening Register will notify people when their results are ready. For very low risk findings, it will let them know this result and that they're due for another scan in 2 years. And it will send screening reminders of when, around the time that scan is due. But for any reports or scans that need any follow-up actions, so from low risk to very high risk and actionable additional findings, the NCSR will just notify the participant that their results are ready. It won't give them the results in the communication, but it will just to let them know that the results are ready to contact their healthcare provider to discuss the results and what next steps are needed. At the bottom is a grey box just highlighting the importance of offering smoking cessation support to the client at various points of contact with them throughout the pathway. The Ask Advise Help model is a quick and easy way of doing this. And of course, while this program is specific to lung cancer, we know ACCHO's holistic model of care may extend beyond this, and points along this pathway can represent opportunities to ensure clients have had their 715 health checks, for example, or GP management plans if these are appropriate, or are up to date with their vaccinations, or any other element that might contribute to their overall lung health or general health and well-being. So moving on to promotion and awareness, healthcare providers will play a central and critical role in promoting and raising awareness of the National Lung Cancer Screening Program. And this can be done by everyone in the ACCHO, from health professionals to support staff such as receptionists and drivers. You'll note the box in the top right that says all staff. We've put the various staff that may play a role in each step of the pathway on the slides over to the right, so everyone can see where they may have a part to play at each step. So to assist with promotion of the program, there will be a national communications campaign where you'll find some early communication starting in July, and then the tailored campaign for priority populations, including Aboriginal and Torres Strait Islander people, will be launching in late September. Tailored information and education resources will also be available from NACCHO to assist with communication with clients. There will also be small grants to support local community engagement and health promotion activities that will be made available for ACCHOs throughout the first 2 years of the program, and we'll have more information on this available soon. And there will, of course, be polo shirts, always popular. So we made sure not to miss out this time. You can see the design for these up on the slide there, but we'll also have other merchandise as well as the shirts to prompt and support conversations around lung screening. So moving on to program entry, the National Lung Cancer Screening Program is a targeted screening program. So the NCSR will not send invitations to potential participants. This makes it different to the cervical screening and bowel screening programs. So it's important for clinics to have processes and systems in place to help staff to identify clients who are eligible or may be eligible for lung screening. So a great first step is to ensure recording of clients' smoking status and history is up to date in their electronic medical record. You can also use clinical software to proactively identify potential participants based on their age and smoking history. You could also discuss smoking history and lung screening during 715 health checks, or raise lung screening opportunistically during appointments when clients come in for something else. So there's multiple different ways that people can enter the program and head towards an eligibility assessment, and also the potential for participants to be referred in for an eligibility assessment by someone outside the ACCHO, such as a quitline counsellor, or for themselves to proactively make an appointment. Once they hear about the program somewhere else, make an appointment with their healthcare provider to have a yarn about lung screening. So these are the eligibility criteria. I'm sure many of you have seen these already. They were defined by the Medical Services Advisory Committee, or MSAC for short, to target people known to be at highest risk of lung cancer. They did this to ensure the program is safe and effective. So MSAC examined many options for defining the proposed program, and advised that its program recommendations, including eligibility criteria, would minimize risk and costs of unnecessary further diagnostic tests and treatments. And they would also be aligned with lung cancer screening programs in other countries, and the key trials provided as evidence for effectiveness of lung cancer screening that they took into consideration. So the criteria are people aged 50 to 70 years old, who currently smoke or quit in the past 10 years have a cigarette smoking history of 30 pack years or over, and we'll go into that in a bit more detail soon, and have no signs or symptoms that are suggestive of lung cancer. So a couple of quick clarifications to make there. It's only cigarette smoking that makes people eligible for the program. So it doesn't, when assessing eligibility, it doesn't include other forms of tobacco use, such as smoking from a pipe and that sort of thing. It's just cigarettes. And important to note also that people are not required to stop smoking to participate in the program. So that was sort of shown in some earlier consultation that was a concern for people, that if they participate, they may have to stop smoking. Of course, ideally they do stop smoking, but they don't have to participate. And you can see over to the right that many staff members can play a role in assessing eligibility, but ultimately it has to be confirmed by someone who is authorized to order the low-dose CT scan. So that would be a doctor, such as a GP, or a nurse practitioner. We'll have some information resources out to assist with explaining what the screening program is with community members. And we'll also have one to help explain in instances, pardon me, in instances where people are not eligible but still have concerns about lung cancer, so things that they can do. So screening is for asymptomatic individuals. That is people who have no unexplained signs or symptoms suggestive of lung cancer. So it's not suitable for people with unexplained persistent symptoms such as a new or changed cough, coughing up blood, being short of breath for no reason, getting very tired, unexplained weight loss, chest or shoulder pain that does not go away. So anyone presenting with signs or symptoms suggestive of lung cancer are not eligible for the program at that time and should be investigated according to Cancer Australia's guide for investigating symptoms of lung cancer. Moving on to the 30 pack year criteria. So pack years are a way of measuring someone's exposure to cigarette smoke over their lifetime. They're calculated by multiplying the number of packs of cigarettes smoked per day by the number of years the person has smoked. So for this calculation, 1 pack is equal to 20 cigarettes. So for example, in its simplest form, 1 pack year is equal to smoking 1 pack or 20 cigarettes per day for 1 year. Although, there of course be variations of that. So if someone smoked 2 packs per day for 15 years, that would also equal 30 pack years. Clinician discretion is needed due to the complexities in calculating a pack year history. And this is acknowledged in MSAC's recommendations for the program and in the program guidelines and other program material, that clinical judgment and discretion is required in deeming whether someone is eligible based on their smoking history. You won't need to record the client's exact pack year history when enrolling them into the program. And once an individual is participating in the program, their smoking history eligibility criteria does not need to be reassessed. So of course, they may age out of the program, or if they become symptomatic, they won't be eligible. They need to be investigated, but the smoking history part of it doesn't need to be reassessed once they're in the program. However, we've received a lot of feedback from the art show sector that calculation of pack years is not an appropriate approach for many clients. So smoking patterns and behaviors can be episodic and dependent on a host of factors, including availability of cigarettes at any given time, financial constraints, differing pack sizes over the years, sharing packs with others, variable means of accessing tobacco, such as loose tobacco, that can be available on the black market. It's also known as chop chop. Alternative routes of smoking. So for example, self-rolled from cigarettes from tobacco pouches, and just the natural variation in smoking habits that will occur over many years and any sort of long-term quit attempts mixed in there. So it's heavily reliant on the individual's recall of their smoking history over many years, or rather decades. There can be language and cultural barriers when attempting to calculate a pack year history. It can be time consuming and inaccurate, and it's not routinely entered into electronic medical records. So to that end, to address this, NACCHO has developed a proxy approach to assessing the 30 pack year smoking history criteria in the ACCHO sector. So we developed this to reduce burden on the ACCHO sector workforce by supporting identification of eligible clients and to optimize use of clinical software and what can be documented in clinical software, and to maximize participation of clients at high risk of lung cancer from smoking. So the approaches, I'll go into more detail shortly, but it's based on duration of years smoked and evidence which shows this contributes to lung cancer risk much more than smoking intensity, that is the number of cigarettes smoked per day. But it's important to note that this is not intended to replace the pack year criterion. It's simply it's an additional tool that can be used at the clinician's discretion if calculating pack years presents a serious barrier to uptake of high-risk individuals. So we just wanted to make sure that there was another approach that could be used in those circumstances if calculating a pack year history is proving impossible. So this resource will be made available very soon on the NACCHO website, and we'll also email it around. But I'll take you through the steps now. So step one is to determine smoking status. Ideally, this information will already be documented in their medical record, so just need to confirm this with the client. If they're currently smoking, you move on to step two and of course offer smoking cessation support. If they've previously smoked, just need to ask what year the person stopped smoking. If it was under 10 years ago, you move on to step two. But if it was over 10 years ago, the person won't be eligible based on their smoking history. And similarly, if they've never smoked, of course, they won't be eligible for the screening program. So step two is just to ask what age the person started smoking. So once again, a simple assessment that's much easier for the client to remember and likely already recorded in their medical record. And it has the added benefit of being a one-off assessment. So it won't change over the years like a pack year history calculation would. So, and the final step is to calculate the number of years of smoking based on the person's current age minus the age they started smoking, accounting for any sort of breaks or long-term quit attempts. So what we determined is if they have a smoking history of 30 years or over duration, this we feel is a fairly good approximation of whether they have a 30 pack year smoking history and would be eligible for the program. And we've chosen 30 years for simplicity as it aligns with the 30 pack years from the eligibility criteria. But we've also based it on National Drug Strategy Household Survey data, which showed Aboriginal and Torres Strait Islander people smoke on average 17 cigarettes per day. So given likely or potential underreporting, this is approximate to the 20 cigarette pack per day used in the pack year history calculation. In the middle blue box, if the smoking history is under 30 years, but your clinical judgment is that the person is at high risk of lung cancer, then you can still deem them eligible. So as mentioned before, when you're taking a smoking history, there's always going to need to be some room for clinical judgment here in determining whether they may be eligible or not. So if they, for example, didn't quite smoke for 30 years, but they've been smoking a lot in that time, you can still make the judgment that they are eligible for the program based on their smoking history. And then the third blue box on the right there is if their smoking history is under 30 years and clinical judgment indicates that the person is likely not at high risk of lung cancer, then you can deem that they're not eligible for the program based on their smoking history. Just noting that they may become eligible in the future. So it's important to sort of keep regularly reviewing their smoking history because if they're not initially eligible and they continue to smoke, they may become eligible at a later time. All right, so that was the proxy approach and the eligibility assessment. So once a client's been assessed as being eligible for the program based on those criteria, the next step is to perform a low-dose CT suitability check. So this involves checking whether your client is suitable to have the actual low-dose CT scan based on their general health, alongside factors relating to a person's ability to physically access and use CT scanners. So the suitability assessment should be performed by the practitioner completing the low-dose CT scan request form, such as a GP or nurse practitioner. But of course, other members of the team can help gather the necessary information to sort of streamline any workflows in the practice. So this suitability check needs to be completed for all people who are eligible to participate in screening and performed before each low-dose CT scan request. So that includes the first one and every subsequent CT scan request afterwards. So people are likely to be considered temporarily unsuitable for low-dose CT if their weight exceeds the restrictions of the scanner and what the scanner can allow. This is typically sort of over 200 kilograms, but it does depend on the exact scanner that's being used. So good to check with the radiology service provider on any restrictions there for the specific details. Also, if they are unable to lie flat on their back for a minimum of 5 minutes while they're getting the scan, if they have a symptomatic lung infection within the previous 12 weeks, that may affect visualizing the lungs and interpreting the scan. So they may need to wait a few months until that resolves. And also if they already underwent a full CT scan of the chest within the last 12 months or have one planned for other reasons, clinical reasons, in the next 3 months. So there's no need to be performing an additional CT chest on top of what they've already had done or have planned for something else. So once they've been deemed eligible for the program, they're suitable to have a CT, you can enter into a shared decision-making conversation. So this is a discussion and collaboration between a participant and their healthcare provider. It's a genuine discussion of all available options, the benefits and harms of these options, and consideration of the participant's values, preferences, and circumstances to make a decision about the most appropriate healthcare for them and whether screening is right for them. So it's a person-centered process that enables people to feel safe and trusted to make informed decisions based on their own values, beliefs, and understanding. It should be performed by the practitioner requesting the low-dose CT scan, but of course other staff members can be involved if the client prefers this, and absolutely, of course, family or other community members can be involved in the discussions, depending on the client's preferences there. So I won't go into too much detail on this today. There will be a tool to assist in this process, which was co-designed with the NACCHO sector and community members by a team at the Australian National University, led by Lisa Wapp and Raglan Maddox. And Lisa will provide more information on the shared decision-making tool and process at an upcoming webinar, which I'll share some details for at the end. So there will be 2 new MBS items for the National Lung Cancer Screening Program that will go live on the 1st of July this year. So these items are for the low-dose CT scans. There's one for the baseline scan and the two yearly sort of regular scan. And then there's another one for any interval scans that they need in between their usual 2 yearly scan to follow up on any findings and to monitor any nodules. So these MBS items are mandatory bulk bill. So the scans themselves will be free for participants, though there may be associated costs such as for GP appointments or for travel or that sort of thing. And that just to note, there aren't new MBS items for consults around lung screening. NACCHO should just use existing MBS items for consults to cover those lung screening conversations. So the item descriptors are available on the Medicare website. More information on these new items, as well as the explanatory notes, will be available from July this year. All right, moving on to the low-dose CT request itself. So in order for them to get the CT, you need to provide them with a CT request. So this can be completed by a GP or other type of doctor or a nurse practitioner. So there's a standardized low-dose CT request form being integrated into clinical software systems for the program, because there's some additional information that you'll see is needed on these requests. So this request form is already available online, so you can see what's in there, but as mentioned, it will be integrated into the clinical software system, so you can order through your software systems. Particular to Communicare, because there was some additional work needed in terms of creation of clinical items and workflows to assist with this. There will be guidance coming for Communicare users in how to set up those clinical workflows to manage lung cancer screening and order the low-dose CT scans. So they're still building this, so the full guidance won't be available on the 1st of July, but they've advised us they will release an interim solution by then for program launch, so that you'll be able to order the CT scans through Communicare. So you can see there's some, well, you probably can't see the form, but there's some additional information needed in the CT request for the program. They ask whether it's one of their regular 2 yearly scans or whether it's an interval scan to monitor a nodule. They'll ask if they've had a previous CT chest, and if known, to list the date and the radiology provider that performed the CT chest. They'll ask for family history of lung cancer, so that's in first-degree relatives, and any history of any cancer. And this is to aid the radiologists in interpreting the scan and using the nodule management protocol. Pardon me. So the low-dose CT scans for the program can be accessed through both public and private providers. It's just best to check with your local provider first to ensure that they are offering these services under the program and that they're offering the bulk billed scans to ensure that your client is getting the free CT scan. And as mentioned before, Heart of Australia are contracted to deliver mobile screening in selected rural and remote communities throughout Australia. Just a final note, where possible, it's best to refer clients to the same radiology provider each time when they have a subsequent scan. This is just for ease of access for that radiologist to the imaging from their previous scan so that they can compare it. That's not mandatory. They can go wherever they like, but that's just a recommendation where possible to refer them to the same provider. And there will be, just to note, there will be some resources that NACCHO will release for community members to sort of assist people in getting ready for their scans, so letting them know what to expect on the day they go in for their scan, and also some information resources to help people understand their lung screening results. So those are all coming soon. So moving on to the final sort of step of this eligibility and program entry portion of the pathway. is enrolling them in the National Cancer Screening Register. So with the client's consent, a staff member with access to the NCSR needs to complete the eligibility and enrolment form to enroll the participant into the program. So this is, as mentioned, this is different to bowel screening and cervical screening, which automatically invites people eligible for screening based on their Medicare data. For lung screening, they need to be actively enrolled by the primary care team. So this form can be accessed through the either the NCSR hub, which is through the integrated clinical software, if you've integrated your software with the NCSR, or through the NCSR healthcare provider portal after searching for the client within the NCSR using their details. So staff with a Medicare provider number or a register identifier number can access the healthcare provider portal. However, if there are staff that don't have this access, they can gain delegate access by a registered user with a Medicare provider number to assist with completing these forms and also to see the participants' information and where they're up to with their screening journey. So up on the screen here is a view of the healthcare provider portal. So it just shows that the client's been searched using their details, their name and date of birth. And then on the bottom there, they should come up, and over to the right in the red box, that is where you'll find the button to press to open up the eligibility and enrollment form, so that you can complete that and enroll them in the program. And this is the view of what it should look like in the NCSR hub through integrated software. So currently, software that can integrate with the NCSR is Communicare Medical Director and Best Practice. MMX, unfortunately, at this point, can't be integrated with the NCSR, although work is underway to make this possible at a later date. So that is happening. But if you click on the NCSR hub button within your clinical software, if it's integrated, it should come up with this NCSR hub, and then you can see again in the red box where you can click on to access the eligibility and enrollment form to enroll the client into the program. So this is what the form will look like, just acknowledging that these images show test data only, and just to give you a sense of what to expect when it goes live, and apologies if you can't see the detail very well on the screen, but it begins with provider details and the date of consultation, and these should automatically pre-populate, so you shouldn't have to fill those out yourself. And then it will ask you to select your organization details, and if you're working in a NACCHO, you can click yes for working in a NACCHO there. It'll then move on to asking you to just confirm that they're eligible for the program. So just to reiterate, you don't have to enter in an exact pack year calculation or anything like that. It's just a yes, no, are they eligible for the program? It then just asks you to confirm that the client has received the NCSR privacy document. So this is a document to provide to them that lets them know how their data will be managed by the NCSR. So really important to make sure people receive that and are aware of that. And then there's a series of questions just asking you to confirm if the client is happy to participate in the program, to share their data with the NCSR, and to receive notifications from the NCSR. And I'll go into those options a little bit more in a moment. It then asks you to confirm the patient's suitability for a low-dose CT scan. So we're just sort of going through the pathway here and what the form asks. And then the next part of the form includes smoking cessation and clinical history. So you can select whether they've been offered smoking cessation support, and if they have, you can select which type of smoking cessation support they've been offered, such as brief intervention, which I believe is up there, and you can select as many options as applies. So you could also put in NRT and that kind of thing. And it will also ask you to select whether the patient has a family history of lung cancer, just like the CT request form. And then the last part of the form is the demographic and cultural information. So you'll select whether the patient is of Aboriginal or Torres Strait Islander origin, and you'll select the patient's country of birth, their language preference, and whether they need any sort of interpreter services. So once you've completed the form, you click on the bottom right review button. You can then review all the selections you've made and information you've put in, edit anything as needed. And if everything looks correct, you can hit submit and your client will be enrolled in the National Lung Cancer Screening Program. So they'll receive welcome correspondence from the NCSR, which includes letting them know that they've been enrolled, and it'll include information on why the low-dose CT scan is important and how to complete the low-dose CT scan. And it will also have some information on there about opting out of the NCSR if they wish to do so as well, and I'll come to that in a moment. A few other things you can do in the NCSR is ask participants about their preferred method of communication from the NCSR. So it can either be through postal mail or SMS text for when they're receiving their screening reminders or notification that their results are ready. Participants can also nominate an alternate recipient of their communication if they don't want to receive it themselves. So this could be a trusted family member or friend, or it can also be an NACCHO member of staff. So important to note that it can't be just an NACCHO itself. It would need to be a staff member within the NACCHO that is nominated as an alternate recipient of the participant's communication, if that's what they'd like to do. So a bit more about those options that we just sort of ran over in the eligibility and enrollment form. So the first one on the left there is that they can choose to suspend NCSR contact. So what this means is they won't receive any communication from the NCSR, so they won't get the mail or the SMS screening reminders or letting them know when their results are ready. But with this option, their data will still be stored in the NCSR. So the healthcare provider, yourselves, can still see their data in the NCSR. You still enroll them using the form. And you'll be able to see sort of where they're up to in their screening pathway, when they're next due, and their results on the NCSR and all of that. But on the right there, they also have the option of declining to have their data stored in the NCSR. So this is called opting out of the NCSR. Once again, they won't receive any communication from the NCSR. But importantly, also their data will not be stored in the NCSR. So there won't be any data related to their lung cancer screening on the NCSR, and they're essentially be considered an external screener, so not formally enrolled in the lung cancer screening program. Very important to note, though, that they can still screen for lung cancer, even if they've chosen to opt out of the NCSR. So they can still claim the MBS items to get the free low-dose CT scans. They just won't be considered a formal participant of the program. And in both cases, the healthcare provider will be responsible for keeping track of where they're up to in screening, sending out reminders when they're next due for screening, and ensuring that there's timely communication of results. So hopefully that's all made sense so far. I'm now very pleased to hand over to Dr. Alice McGushan, a public health registrar at Woononga Namitja Aboriginal Health and Community Services in Canberra, who's going to showcase some of the great work they've been doing to prepare for lung cancer screening. So I'll stop sharing my screen. We'll see if we've hopefully got Alice online.
Yeah, thanks, Jeremy. Thanks. Yeah, so I'm just going to share my screen showing live kind of a few of the different documents and the communicator item that we prepared so far. But just a little bit of a kind of overview of what we've done here at Woononga so far. So I'm, as Jeremy mentioned, I'm a public health medicine registrar at Woononga. And Woononga is the Aboriginal Community Controlled Health Service, servicing all of Ngunnawal and Ngambri country in the ACT. So in preparation for the lung cancer screening program, we started by kind of reviewing the program guidelines, establishing regular communication with NACCHO, as well as ACT Health, who are coordinating rollout of the lung cancer screening program in the ACT. We're providing regular updates to our clinical staff. Have also communicated with our internal teams within tackling Indigenous smoking, and also our No More Bunda program, which is our stop smoking program at Woononga, to kind of discuss future promotion of the program, as well as capacity for No More Bunda to receive new clients when smoking cessation is offered during the program. The next thing we did was to kind of get an initial idea of clients who could be potentially eligible for the program. So we use Communicare. And so we extracted the data on all clients aged between 50 and 70 and their smoking status. What we found with that data was it was incomplete. So we didn't have smoking statuses completed for all clients aged 50 to 70. So we decided rather than put a further drive on our clinical staff to just capture that information on smoking status, that we would instead preemptively develop, start capturing the full information on screening program eligibility. So I'm just going to share my screen and show you what we've developed. So this is the Communicare item that we have prepared at Woononga. And so what this first captures, the first information is more detailed than the initial smoking status information. This is actually the information that's in the new health check form on Communicare, the new health check Communicare clinical item. So that captures smoking status, number of cigarettes smoked per day, year commenced smoking, smoking quit date, and smoking quit attempts, and any duration of abstinence. And so that information is also collected in the health checks. So then that means, because they're the same, it's the same information, that if that has been gathered previously, then that will auto-populate into this form. And then we've captured the information on the eligibility for lung cancer screening. So aged between 50 to 70, free from symptoms and signs of lung cancer. And as Jeremy referred to, we have kind of further information on the investigation of lung cancer symptoms tool by Cancer Australia there for that. And then the next one, as mentioned, whether they're currently smoking or have quit in the last 10 years. In line with what Jeremy spoke about, the first smoking criterion that we have about duration is whether they've smoked for 30 years. And so our staff will first fill out that. So if they've smoked for 30 years, they're automatically eligible, as Jeremy mentioned before. If they haven't smoked for 30 years, what we've put in there, similar to what Jeremy presented, was does the clinician estimate that they have at least a 30-pack year history of smoking? And then they can complete that. And then the final question is are they eligible for the National Lung Cancer Screening Program? So alongside this, I developed a simple flowchart for our clinical staff so they'd understand how to use the form and what to do next. So this is basically each step of completing the form and what to do if at any point we don't progress down the screening program pathway. So, for example, normal investigation pathways for lung cancer if they have symptoms of lung cancer. They're not eligible if they've never smoked or they quit more than 10 years ago. They're not eligible if they have less than a 30-pack year history of smoking. After if they've smoked for less than 30 years. And so what we've done from here is we've started using this Communicare clinical item opportunistically since the end of May. It currently only involves a smoking assessment rather than a discussion about the lung cancer screening program. And the reason we've done it that way is because we don't want to raise expectations about the screening program ahead of time, because there are a number of uncertainties about the screening program still at this point. So there's other things to be finalised, such as the radiology providers on board providing the CT scans and the ACT. And so kind of the next steps for this, as Jeremy mentioned, we're kind of still, so we're still waiting for an update from Communicare about that kind of interim measure. So we haven't really had any information from Communicare about this yet. We're waiting for that final information on radiology providers. So kind of confirmation of weight limits, availability of hoists if required. So that information is kind of slowly trickling through. We're going to get an update from our PHN about the kind of the detailed pathway for in terms of referrals to radiology providers, onward referral to specialists. That's coming next week. So in preparation from following the 1st of July, I've developed a more detailed kind of screening assessment pathway, which kind of captures at least what's going to happen internally at Woononga in terms of the Communicare item, so completing that eligibility assessment, then enrolling them for the screening program on the NCSR hub, then completing the CT suitability assessment by GPs and also NPs, which I'll need to update, and then providing further flowchart on the CT suitability assessment. And then I've captured in there as well the information on kind of repeat screening and also the follow-up CT assessments, making it clear to our clinicians that for all CT scans, that CT suitability assessment needs to be completed. But also for the repeat screening, as Jeremy mentioned as well, we no longer have to do those kind of smoking assessments. We no longer have to assess those smoking criteria, but we still need to make sure that they haven't aged out, and we need to make sure that they don't have symptoms of lung cancer. So I've added that in the flowchart as well. And there'll be an update to the lung cancer, the eligibility assessment clinical item that I just shared. So we'll add in further information on the differences between the initial assessment and future screening assessments, as well as adding in that suitability for a low-dose CT as part of this clinical item. So that will be coming in. We won't add it until the 1st of July because that's, we can't make that assessment ahead of time. And then I've also mocked up another clinical item, which will be reporting the results. And so that will capture the results, looking at all the different ones that Jeremy presented in the pathway, and then the actual action required. So whether that's a specialist referral, a follow-up scan, or kind of continuing in the program with the every 2 yearly scans. So I will stop sharing there. So in terms of what we're going to do from the 1st of July, as I kind of alluded to, the rollout of the program just seems a little bit uncertain in terms of its functionality at this point. So we're not going to start a full active recall of clients to do those eligibility assessments yet. What we will do is, as I mentioned, we've already have this opportunistic eligibility assessment running. So we will start with a recall with just those clients, and then we will test the system by referring them to have their CT scan and then await the results. We want to make sure that there's kind of an appropriate wait time for the actual scan itself and the actual results before we do a full-blown rollout with recalling a lot of clients, undertaking the assessments, and then setting up the expectation for those CT scans and the results. So yeah, as I mentioned, we'll test the system with these opportunistic clients. And then once it's clear that the system is working, then we'll begin a rollout of recall for a further kind of eligibility assessment, starting with those clients who have a smoking status recorded as current smoker or ex-smoker. Thank you, Jeremy. That's all that I have to say. I'm happy to answer any questions.
Awesome. Thank you, Alice. I think there's just a question from Amanda in the chat, just asking if they can have a copy of the flowcharts. Feel free to answer that now or take it offline. You may need to sort of check with others at Woononga. Yeah. All right, thank you so much for that. Really awesome to see the great work that you and the Woononga team have been doing to prepare for the program. So really appreciate you sharing that with all of us today. And I think sort of your approach of a soft program launch is very reasonable. So perfectly acceptable to just make sure that your practice and your staff are you know, wrapping their heads around this entirely new process, entirely new screening program, and making sure that those workflows are sort of in place and working well before really getting proactive with recruiting clients can be a really good way to go if that's what you feel is best for your practice. I think that's a good approach. So I'll just reshare my screen. All right, so here we've just provided a few sort of resources that will be available to help you get ready for the National Lung Cancer Screening Program. So as mentioned in the webinar, NACCHO will provide tailored resources for healthcare providers and community members and participants to assist with providing information about the program. So you can register to be notified when, as and when new resources are published. To begin with, I've listed one over on the right of the screen there, which is essentially a checklist to assist you with getting yourself and your practice ready for the program launch. So you can scan the QR code to download the checklist, but it's also available on the NACCHO website. There's online training, so Lung Foundation Australia have online training modules for healthcare providers to educate you on the program and how to implement it. And you know, these are you can start these and then come back to them later, so you don't need to finish it all at the same time. And then, of course, there are the NACCHO webinars, which you're participating in at the moment, but there'll be more to follow. So these will be live, but as mentioned, we'll record these and we'll make those recordings available after each webinar. There is also information out there on the National Cancer Screening Register. So already online there are guides for clinical software integration and how to access the healthcare provider portal. But they are also developing lung cancer screening specific guides, such as quick start guides, and videos to help you navigate the portal and where information will be and forms you need to fill out and that sort of thing. So that will all hopefully become available soon. And then finally, I'd like to plug the next webinar that we've got coming up next week on Wednesday, the 25th of June. So this one will be on shared decision making for Aboriginal and Torres Strait Islander people. And we're very lucky to have Associate Professor Lisa Wapp as a guest presenter for this webinar. And she'll be taking us through the awesome resource that her and her team at ANU have developed to assist in the shared decision making process for lung cancer screening with Aboriginal and Torres Strait Islander clients. And you can scan the QR code there to register, but I think we'll also drop a link in the chat, I think. All right, so this brings us to the end of the webinar. Thank you so much, everyone, for joining us today and taking the time out of your busy schedules to be here. It looks like we've reached the end of our time, so if there are any questions in the chat that we haven't got to, apologies for that, but we will, as mentioned, collate them into an FAQ document, and we'll send that out after the webinar so that these questions will be answered and everyone can see the answers. We're also always happy to chat, so please reach out if you have any further questions or feedback. We've put our cancer team email up on the screen if you'd like to contact us. Always happy to have a yarn, so reach out if you'd like to. But thank you again, and enjoy the rest of your afternoon.